Good day, ladies and gentlemen, and welcome to the How FirstNet Can Help EMS Provide Better Patient Care webcast. All lines have been placed on a listen-only mode. If you would like to ask a question during the webcast, you may do so by clicking on the Ask a Question button located below the presentation. Simply type your question into the box and hit Send. If at any time you may be experiencing technical difficulties, please use the Ask Question button to send us a message, and we will reply for assistance. At this time, it is my pleasure to turn the floor over to Noah Smith. Noah, you may begin.
Thank you, Gabe, and good afternoon or good morning, everyone. Welcome, and thank you for joining EMS Focus, a collaborative federal webinar series. My name is Noah Smith, and I am an EMS specialist at the U.S. Department of Transportation, and I'll be your MC for this webinar. Together with our federal partners, the National Highway Traffic Safety Administration's Office of Emergency Medical Services is focused on advancing a national vision for EMS. The projects we undertake and the resulting resources for the community help plan for system improvements by measuring the health of EMS systems nationwide and delivering the data that EMS leaders need to advance their individual agencies. Another role of the Office of EMS is to educate the EMS community on new innovations, processes, and technologies that can, in the end, help provide better and more efficient patient care. This free webinar series, hosted by the NHTSA Office of EMS, will provide a unique opportunity for federal EMS agencies to share information with the EMS community in a manner that is more personal and less time-consuming than attending conferences, yet still offers the opportunity to interact and ask questions, something that a newsletter or an article simply doesn't allow. We host these webinars every other month about issues that are important to the EMS community and provide you with timely information about what federal agencies are doing to help address those issues. Today's webinar is being recorded and will be archived on our website, www.ems.gov, for future viewing and listening. Moving on to today's topic, how FirstNet can help EMS provide better patient care. First, we will hear from Kevin McGinnis, a FirstNet board member. He will share information about some of the applications and expected benefits of the network for EMS, as well as talk about how EMS has been and continue to be involved in the development of the public safety broadband network. Then we will hear from Amanda Hilliard, Director of Outreach for FirstNet. She will discuss current FirstNet outreach, including the state consultation efforts, and explain how EMS communities can get involved. Following the presentation, we'll have time to answer your questions. And just as Gabe said, to submit a question, please click the question button at the bottom of your screen, then type the question into the chat box. We will not be addressing questions during the presentations, but instead we'll address your questions submitted at the Q&A time period following the presentation. If your question is not answered for any reason today, we will provide a follow-up email to you directly, and we'll also provide an email address for additional questions at the end of the webinar. During this webinar, we'll take a look at why the First Responder Network Authority's efforts to build a nationwide public safety broadband network is important to EMS systems across the country. Much conversation has focused on how the network will help first responders and its potential role in major events, such as the Boston Marathon bombing and the Navy Yard shooting. But we can also expect that EMS will see day-to-day benefits from the implementation of this network. Although the Office of EMS isn't directly involved in the development process, it's our mission to share information and resources with the EMS community about activities that, at the federal level that may affect your state or your agency. And so with that in mind, and because the FirstNet Board continues to request input from the states and the public safety community, we hope the presentation today provides you with the background information that you need so you may join the conversation and communicate the needs and concerns of your stakeholders, your EMS agencies, to the appropriate contact within your state. Kevin and Amanda, we appreciate you joining us today to talk about how FirstNet is reaching out to EMS and how providers, managers, and state officials can participate in the process. Our first presenter, Kevin McGinnis, started his career in emergency medical services almost 30 years ago and is nationally known and recognized as a supporter and advocate for broadband communications within the EMS community. Kevin is a member of the FirstNet Board, and he joins us from Maine. Take it away, Kevin.
Thank you, Noah. I hate to say it, but it's really almost been 40 years, and time just flies when you're having fun. And I have had fun, a great career in EMS. One of the things that I got involved in about 10 years ago was public safety communications. It was sort of as though I was the one in the room who didn't step back fast enough when somebody said who would like to represent EMS in public safety communications venues. But in that time, I've had a good deal of opportunity to learn public safety communications and to be very involved in trying to represent a large EMS community here. 6 years ago, an amazing thing happened. National organizations that represent fire, law enforcement, and EMS all agreed on something that is amazing. They agreed that every paramedic, cop, firefighter should have in their hand on the scene at least the technology that the average 13-year-old enjoys today, because we don't have it. Today, Amanda and I will tell you how FirstNet is going to accomplish this, how it all came about. Let me give you some EMS examples of what FirstNet will enable. We'll talk a bit about the development status of the network as it stands today and how you can get ready for FirstNet to take advantage of everything it can bring, because FirstNet is going to make a profound change in the way EMS is practiced in the field. It's going to allow us to make better decisions and with more and better information at our fingertips in real time. And as I said, I will give you some examples of that. And I predict that EMS over fire and law enforcement will be the biggest user of FirstNet in the coming years. So as folks know, we had a sea change in ambulance service in the late 60s and early 70s. We went from essentially being a horizontal taxi cab service to a sophisticated, modern, mobile medical service that can save lives and bring tremendous capabilities to patients at the scene of their illness or injury. One thing that did not change from the early 1970s, when modern EMS really was born, to today is the way we communicate. By and large, the same land mobile radio, VHF, UHF systems that we used in the early 70s are what we're using today. And even though some of us have gone to 700 and 800 megahertz systems, and we use cell phones a lot more, by and large, those narrowband, and I'll talk about what narrowband means later, systems are not going to support us into the future. There have been a number of studies that have indicated that we need to move beyond the communication system of today. And in the last 10 years, I've held multiple focus groups and expert panels to try and help me understand what the needed technology in the field is going to be in the next 10 or 15 years, so that I can go out and put 2 cents worth in at the planning tables for the kinds of resources, infrastructure, bandwidth, and other resources that EMS is going to need to support that technology. And today, what I will do is, out of all of those interactions with EMS medical directors and chiefs and medics and EMTs and others, telling us what kinds of technology we need, I will provide some examples. This is not all coming out of my head by any stretch. However, let me give you just a little slice of what that world is going to look like, and we'll push out our first video.
Miss Woods, you've been in an accident. Do you understand me? Given the nature of your injuries, we'd like you to speak to a specialist on video. Is that all right?
I'm Dr. Greer. There are a few questions I'd like to ask you.
Given the video has concluded, you may proceed.
And that played successfully. I wasn't able to see it on my screen. So that's just a taste of what we may have in store for us in the future. The exact technologies may be different, but it certainly is quite a bit different than what we have today. Those focus groups and expert panels produced 4 overall conclusions of needs that we have in EMS coming to the future. The first is a need for situational awareness. That is to say, and this is something that's well known in emergency management, law enforcement, but virtually unknown in EMS. That simply is that we have a perfect knowledge of the resources that we have to bring to bear on our next call for a patient we're going to next encounter, whether it's a trauma center or a helicopter, extrication unit, or additional ambulances or crew. We know where they all are at any time in real time. And we also know all of the events going on around us, whether there are other EMS calls going on, anything that will take resources away from our current needs and our patients' current needs. The second is common operating picture. EMS, by its nature, is a team sport, more so than law enforcement or firefighting. Every call that we have involves more than one player, one responder. It involves an EMS medical director, online or offline, with us. It involves at least a crew of 2, if not first responders, and other responders coming to the scene, perhaps in a helicopter. And it's important that they all have their own situational awareness, but also that at any given moment that the whole team, whether they're in the hospital or in the field, has a common expectation for what's going to happen to that patient in the next 5, 15, or 30 minutes. Next, that we need to move from a world of where we're wandering our way through calls by sequentially processing information. That is, the tone goes off, we get a location and idea of what the call is about, and then in the next couple of minutes we may learn something more about the location or the condition of the patient or patients, and we revise our picture of what's happening out there. And we do this throughout the call, getting pieces of information and revising our picture of what we're going to encounter and what we're going to need. We need to get to a point where we're parallel processing information, where we have all of the information that we need to manage that call well at our fingertips. Not pouring into our heads or our ears or our eyes at the same time, but at a place or in places where we know where we can get to them. And finally, we need to have the ability to adopt technologies, whether it's diagnostic or treatment technologies, that are available today that we don't have the ability to do because we don't have the communications to support those. In order to get to that place and realize situational awareness and common operating picture, et cetera, we need to have a network of databases out there that list, that has the status of those resources that we need to know about, whether it's hospital status or air medical status, et cetera, and the status of other events going on around us. Something that we can reach out to and access the information in that database that has been updated in real time. It's updated as of a minute ago, not an hour ago. And we need to have adequate bandwidth to be able to use some technology that we can't use today and to actually exchange data as we want. And we got to learn a new way of operating. Voice communications need to be treated as what they are, which is a bottleneck, not a facilitation. The ability of a paramedic, a busy paramedic in the field, to talk to a busy emergency room doctor and have a conversation about a patient and what needs to be done is a window of time that doesn't happen as easily as it used to. And so it's important that we be able to take data that we have at our fingertips, push it out and park it in the database. So when our doctor is then available, they can go out and grab it, pull it in from that database, consume it, and then push the data out to me, the paramedic in the field, who, when I have a spare moment, can then go access that database and pull the information back into myself. And then finally, to access those databases, we need to have interfaces that work for paramedics, that work for doctors, whether it's a PDA, whether that's a smartphone, a mobile data unit in the ambulance, or a desktop PC in the emergency department. We need some way to look at these databases. And because we're visual people, it might look something like this in front of you, a picture depicting the response area of Ridgeway EMS 1 ambulance, with critical information immediately available on the screen, like the status of hospitals, the status of air medical, and then each one of those data points or icons can be clicked on and drilled down. So you can see that Ridgeway EMS has a crew of McGinnis and Smith, and that one's a paramedic and one's an EMT. You can see the status of the volunteer ambulance next door at the hospital and the trauma center. You can click in the lower left-hand corner on the inventory of the ambulance. And if you can picture walking into an EMS base today, in order to check out the rigs and get the information that's portrayed on this screen, it takes a better part of an hour, inventorying 2 ambulances, let's say, calling the hospital to find out their status, the air medical system to find out its status, etc. It's a lofty piece of work. When instead, you can click onto this screen, and suddenly all of this information is consumable by you in 5 minutes, and you're ready to go into this call. So let's talk about some examples. And I know people will cringe when they see the word the golden hour, and this is mostly used for public consumption. But let's talk about time-dependent conditions and, let's say, trauma. Whether it's an hour or it's 15 minutes, there are certain things that are just truth. And those are that in time-dependent conditions like trauma, we don't have a lot of time. And when you define the start of that clock running as this moment that the event happens that creates an injury in you that will kill you, ultimately, to the point where a surgeon, the very last moment where a surgeon can actually fix that injury so that you don't die. It's probably not 2 minutes. It's probably not 2 hours, but somewhere in between. And what we do know is if that event is a car crash, we probably don't have, as is the case today, 20 minutes for that car crash to be discovered and reported and the 911 system to be activated in a rural area, 20 minutes for me to get in my ambulance and go out to the scene, or 30 minutes or whatever it takes in a rural area response, to go out to that scene and discover that the patient really is going to die if we don't do something. The 15 minutes to get the helicopter up, out, and to the scene, and 40 minutes back to the trauma center. That's time that you probably just don't have. Now, fast forward to the FirstNet world. Instead, when that car crashes, a pulse of data is sent by OnStar, ATX, or other systems in an automatic crash notification alert. That data could go straight to a public safety answering point and then be reprocessed, retransmitted onto our smartphone. So when the call comes in, immediately, within a minute, not 20 minutes later, we know we have a crash. We know where it is. We know how bad it is. We know what kinds of forces acted on the car. And generally likely condition of patients. That just saves us 20 minutes out of, call it whatever you want, but the time-dependent condition. With advanced automatic crash notification, you'll see in the upper left-hand corner, we can program into the system the ability to take the data coming out of the car and give us a probability of a severe injury, in this case 92%. Think about what that allows us to do in the future in terms of planning for crashes. The local air medical system can say that automatically, if we have a certain percentage likelihood of injury, that they'll put the crew in the helicopter. Another percentage that they'll turn the helicopter on, another one that they'll launch and head to the scene. The same thing for extrication services or additional resources. And then we don't have to wait for Kevin to get to the scene to determine it's the bad one. And we've just saved, 20 minutes, 40 minutes, an hour out of that time-dependent condition. But the ability to take the data from that car, send it to a processing point, and then get it onto my smartphone requires a fairly large data pipe. Another benefit in that crash from that data goes to the folks coming out to do extrication. Just-in-time learning can be facilitated by having that data on the screen of the smartphone of one of the responders and bringing up the instructions for that particular make and model of car on where to cut and not to cut to best get the patient out of that vehicle. So what we've just done is parallel process a whole bunch of information on the smartphone screen or the mobile data unit in the ambulance. This is what we can have as we roll out of the ambulance instead of not knowing and wondering our way through the call. We know when all of the responders that are involved in the team are going to get there. Gives us a common operating picture of what we're going to see from the data pulse in the car. And so everybody knows what everybody's doing, and we know what the patient's condition is. Quite a bit of change, and that's something that is our future. Then when we get on the scene, if you think about what happens when you get out of the ambulance and go to see your first patient at the scene of the car crash, it's probably a 6 to 10 minute process to approach, make sure it seems safe, establish contact with the patient, gather information from the patient, do some immediate care, call the hospital, have a conversation, decide what the patient's what's going to happen with the patient, and so forth, and then move on to the next patient if it's not being triaged by multiple folks. So instead, let's look at the future with FirstNet. Instead, I hop out of the ambulance, I turn on a video cam, Google Glass or what have you, on my helmet, and start transmitting a live picture of the scene and the damage done to the car and eventually the patient into patient database number 1. I turn on a throat mic and start dictating a note, which is voice to text translated into a Word document or other file, and put in patient database number 2. I come up to the car and I take a device, picture the tricorder for you Star Trek fans, and flash it in front of the patient, and I get stand-up vital signs indicating the patient is alive and we should continue proceeding to treat the patient. So we put a small playing card deck size monitor on the patient's chest, which starts sending out multiple vital signs into patient database number 3, and we connect with either a device on the patient's a USB dongle that the patient wears around their neck, or we get a number from them, an ID number, which allows us access into the Health Information Exchange network, and we download their medical records so that we know what their history is, significant history is. And that goes into patient database number 4, and it all looks something like this. Please push out the second video.
Okay, start record. We have a passenger truck, what appears to be one driver. Vehicle is on wheels, moderate damage to front, appears to have been in frontal collision. Stop record. Excuse me, sir, can you hear me? Excuse me, sir, can you hear me? Okay, I have a positive radial pulse and I have an unconscious patient. Start record. We have what appears to be a large laceration to the right forehead and right face, bleeding down the neck onto the chest area. No obvious major deformity to the chest, abdomen, or lower extremities. Sir, can you hear me? Can you hear me? Can you open your eyes? Okay. Patient's responsive to pain only, does not answer questions. We're going to be transmitting vital signs right now. Okay, I have a medical history tag, and I'm going to submit it for transmission. Okay. Medical history being transmitted now. Okay, let's move on to the next patient.
Well, thank you. What we just saw was the populating of those 4 databases in a matter of 60 seconds. In 60 seconds, those databases are now accessible to the physician in the emergency department, the incoming air medical crew, for use without having to interact with a medic on the scene at all, at least initially. 60 seconds instead of 6 to 10 minutes. Imagine the efficiency that will produce for us. Some other applications that we might encounter in the future. Two-way video, particularly important in rural settings, also in community paramedicine settings, which is a new forthcoming practice within EMS. The ability to guide a patient in the field or guide an EMT in the field on the way in a 90-minute transport to the big city at a time when a helicopter couldn't fly and the patient basically stable when they leave the hospital, but suddenly 20 minutes in turns a color that the EMT's never seen before. Wouldn't it be nice to be able to have a virtual doctor there? Portable ultrasound, another good example of technology. Portable ultrasound is used today in helicopters and ambulances, but it's generally interpreted by folks who use it often enough, and because they're seeing the sickest of the sick every day, to be able to interpret it. But wouldn't it be nice, again, when you have that car crash in a rural area, to have an EMT be able to wand the patient's abdomen and, based on whether there's blood where blood shouldn't be or there's not, the decision is made to call the helicopter and send the patient to the trauma center or to go to the local hospital. In either case, whether the life-saving solution is chosen or the local hospital solution is chosen, it's a right solution for the patient, for the healthcare system, in terms of savings of resources that otherwise might not have been needed. Picture being able to monitor 20 patients at the same time of a mass casualty incident by putting a remote device like the one seen on the right here on 20 patients and then monitoring their condition, getting better or getting worse, and sending perhaps scarce EMS personnel to patients who seem to be having problems. You can also use the same kind of technology in monitoring firefighters at a fire scene, for those that are responsible for overseeing responder condition. And I would just say at this point that of the predicted technologies that are going to require special communications, we have 3 or 4 dozen, and I would refer you to the National Public Safety Telecommunications Council EMS Committee report that has over 3 dozen different technologies recommended to be supported by FirstNet. You can find lipstick on the web. But one thing I'll tell you, everything I've just described, our communication system of today won't support. Nothing, none of it. The reason for that is the pipe that we use, the narrowband pipe we use for VHF, UHF, 700, 800 cell phones, is so small that the only data that it will transmit data at the speed of 20-year-old dial-up. So picture dial-up today. That's 6 times faster than old dial-up. And picture trying to download something on dial-up internet access. We need to have something different. So, as I said, in about 2006, we realized the need to have a nationwide public safety broadband network dedicated to public safety. And national EMS organizations, fire organizations, police, and public safety communications organizations got together and put on a 5-year campaign on Capitol Hill with the administration. And in 2012, a law was passed which created FirstNet. It brought with it the network, LTE technology, which is a chosen technology, 4G technology, some spectrum in beachfront area, which is very useful spectrum for us. It brought us $7 billion to begin building the system, and a direction that ultimately the system needs to be self-funded through fees. But the board of FirstNet also recognizes that in the future that system is going to have to be saleable to every EMS chief out there who has to make a decision of whether to renew the capabilities they have today or go to the FirstNet capabilities. But ultimately what we're going to end up with is an AT&T or Verizon, if you will, of for public safety alone. And the vision that we have is like this. Today, we have data and voice communications primarily through commercial wireless. There are a lot of ambulance services out there that use data, that send data, send patient run records back to the base for aggregation and that sort of thing. But none of those communications are mission-critical, patient-critical communications, and they shouldn't be, because commercial wireless is simply not reliable enough or public safety grade enough to start basing our patient operations on their use. We use for mission-critical communications today is still land mobile radio, the UHF and VHF radios I described. They are reliable enough. In the near term, it's going to change a bit. With FirstNet, we will have mission-critical, capable data communications. That's the primary function of LTE technology that we're using. And it's for doing the types of things I just described. For the time being, however, voice communications, mission-critical voice communications, will still need to be done over land mobile radio. So while LTE does support voice, if you have one of those early devices today, you'll know that they are not particularly reliable. But in the long term, certainly the goal is to have over the FirstNet network combined voice and data capabilities. And so that is our future. So what can you do to get involved in FirstNet and its development? First of all, every state has a single point of contact for the development of FirstNet. They've been named by the governor. Get to know who that person is. Every one of those has developed a committee of some sort, which is supposed to be a representative committee of public safety, including EMS and hospitals, to help in the development and the integration of FirstNet into that state. Find out where that table is, get to the table, and speak for EMS. Make sure that there's somebody there doing that. You're going to need to determine what kinds of technologies you want in your area in the future. Is it the ones I described, or is there other ones that Mystic has described in their white paper? Follow FirstNet on the web. And Amanda is going to start now, and she will describe the specific websites that you can go to later on to do all of this. Amanda?
Great. Thank you, Kevin. And thanks, everyone, for joining us. So what I'm going to do for the rest of the presentation is give you a brief update on the past activities within FirstNet over the last year and highlight some of our key activities that we're working on right now. Our top two priorities right now are consultation with the public safety community across all disciplines, all levels of government, as well as our acquisition to make this network a reality. Last March, our board released a roadmap with some of our key milestones for the coming year. I'm pleased to announce that we met three of those major milestones. And this snapshot here, which I'm going to build on in my briefing, shows you some of the major next steps that we have coming up, which I'll build on here. So absolutely critical to our success is to get significant input and engage the public safety community. And we have a number of different ways that we are doing that. One, through our public comment process. And in that process, we had our first public notice that we released back in September. We got 66 responses, and this is a way where we get some input on key topics. So for the first one, we asked for feedback on our definition of public safety entity, who we envision being eligible users for the network. We also asked for some feedback around our definition of rural. As you may know, FirstNet is required to have some rural milestones within each phase of the network, so we wanted to ask some questions around that. Regarding our acquisition process, we released a number of requests for information over the last year and a half or 2 years, some very specific on devices, applications, and most recently in September of this past year, we issued a comprehensive request for information in which we laid out some high-level statement of objectives for our procurement and essentially asked for feedback on that from industry in terms of what industry may be able to provide for our effort, and from the public safety community in terms of what does public safety expect. We know that Kevin had mentioned the $7 billion that we have for this effort. We know that that's not going to be enough, so it's very critical that we find a partner or partners to engage with us to help build the network, operate it, and maintain it. So where we're at right now with our acquisition, we got a lot of great response from that latest RFI. We had 122 responses that we're working through, and we are working to release a draft comprehensive network proposal in the near future for feedback before ultimately issuing a final RFP. Our outreach engagements, what we're doing here today, we spend a lot of time talking within the states. Each state has some grant funding to help do outreach on FirstNet, so we support those efforts. We're very engaged with many of the national public safety associations. Really just in this way, we're focusing on our education and awareness of FirstNet. The Act required us to create a public safety advisory committee, which was one of the first actions that the board took upon being stood up. There's 40 members of the PSAC, including on the EMS side, the National Association of EMS Officials, the National Association of EMTs, and the National EMS Management Association. And we engage with this group regularly. They have a few tasks right now that they're going to be starting to have some dialogue and provide us some feedback, in particular very soon, on priority and preemption and public safety grade. So that's been a great forum for us to get some really good input from the public safety community. And then the last area, which I'm going to spend the next couple of minutes talking about, is our state consultation efforts. You see here on the slide, the Act specifically calls out a number of topics that we have to engage with each state and territory on: construction of the radio access network, assignment of priority to local users, training needs. And we have formally launched our consultation process with all 56 states and territories, and we do this through that state single point of contact, or SPOC, that Kevin had mentioned. On the federal side, we are also working to do a similar consultation process with the federal departments and agencies, as they will also be, the public safety community will be users of this network. So this next slide here, the Act requires FirstNet to develop a state plan for each of the 56 states and territories, that red box there on the slide, which will essentially be presented to the governor to make an opt-in or opt-out decision within 90 days. So if the governor receives the plan, and the plan is for how FirstNet would build the radio access network within the state, the governor can opt in, and in that case, FirstNet would proceed forward with the responsibility for building, maintaining, and operating the network. If the state decides to opt out, and there's a detailed process for that I won't get into, but if the state successfully opts out, the state is essentially taking onus and responsibility, financial responsibility, for building, operating, and maintaining the radio access network portion. Regardless of the opt-in or opt-out decision, the RAN will connect to the FirstNet core, so again, it's a single nationwide network. So what this slide shows here is essentially the processes, some of the activities that are taking place to get to this state plan, and you can see we're fairly early in this process. We have to get through an acquisition. As you can see, we need to have results from that comprehensive RFP that I briefly talked about. That's where we'll get some of the cost information, some of the design information. Essentially, that's all needed before we can ultimately deliver the state plan for how the radio access network would be built within the state. You can also see some of with the arrows, how the consultation process that we're engaging in now is informing our RFP process. And essentially the last point I wanted to make is that this consultation effort will continue well after the state plan. So we envision we would continue to engage with the states and the local community within the state as we start to build out and ultimately grow the network. The next slide here gives you a snapshot of where we are with each state and territory in terms of our initial consultation, which again, we are coordinating through that state single point of contact. Back in April of last year, we released an initial consultation package to all 56 states and territories and requested some documentation regarding, governing bodies, outreach that has been done around FirstNet, current use of mobile data, things like that. And as you can see here, 46 of the 56 states and territories have provided a response back to FirstNet with some of that information that we are using to then go and have an engaging initial consultation meeting. Our goal is to meet with all 56 states and territories by the end of the year. We have 13 that are complete so far, and we're working very hard and have meetings scheduled almost every week for the next several months to, again, get to all 56 states and territories. If any of you reside within the 10 states or territories that we haven't yet received a package back, I would just note we're in regular contact with all 56 states and territories. So we know that many of those will be coming very soon. Let me talk for just a few minutes about what this first initial consultation meeting entails. The agenda for the day, or some of the goals that we have, first and foremost, to strengthen our relationship with the state and the local public safety community. Second, to provide FirstNet updates. We spend a bit of time kind of catching up, making sure that everybody in the room is on the same page of the program and sort of where we're at right now. Spend a lot of time answering questions. The third part is around learning about the state's unique needs, and this is the place in the agenda where some of the local public safety folks come up and essentially provide a presentation about maybe an incident that they responded to or a planned event, how broadband is being used today, how it's working, or if it's not, how they would envision using it in the future. And we've received some really good use cases and input that we're working to incorporate into our RFP process. And then the second half of the day, we spend discussing users and coverage and some next steps. So the next slide here kind of shows you that afternoon discussion that we have. We take some time with the participants in the room talking about the process that FirstNet has established for determining some baseline coverage objectives for each state and territory. Essentially, we're looking at, where do public safety responders reside, some of the critical infrastructure, highways, things like that. So again, just establishing a baseline of coverage objectives for the state. And then essentially the next step is for that SPOC to go out and engage with the community across the state, all disciplines, to really validate and add to those objectives. What are some unique things about that state or territory that we didn't cover in the baseline that are absolutely critical for this network? The second part is wanting to understand a little bit more about users. We have some general numbers from census and other data sources on the number of public safety officials, but really wanting to work with the SPOCs to validate and update some of those numbers. Also begin to understand, for those that are currently using mobile broadband today, what kind of usage and data consumption. So the SPOCs will likely should start collecting a lot of this data, having discussions within the state around coverage and capacity and users. So I would just encourage you, you'll probably be hearing more about this in the next couple of months from your state single point of contact, and I would just ask for you to get involved with that process. We have some general information from some sources, but the more data and the more specifics we can gather from the community, the better we'll be able to really build this network to meet your needs. The last part I just wanted to touch on, I mentioned this a little bit with the state plan, is the main components of the network being the core, the radio access network, and our devices and services, and where there will be choices. So for the core network, I mentioned this is a FirstNet responsibility. It's a single nationwide network. Regardless of that opt-in or opt-out decision, FirstNet owns responsibility for that core network, kind of the brains behind the network. In terms of the radio access network, I had mentioned a plan will be delivered to the governor for how FirstNet envisions implementing the network within the state. If the state chooses to opt in, FirstNet will, again, take responsibility, all costs, for building out, maintaining, operating that network. If a state successfully opts out, the state is taking on that responsibility. And then last, in the area of devices and services, and this is completely an agency's choice. No one is required to use this network. Our goal is that, after we get all this input and work through our acquisition, the state planning process, get the network rolled out, that people will be very eager and anxious to sign up. So again, the devices that we would offer, the services that we offer, that would be up to an agency to decide what to purchase. So lastly, Kevin had mentioned, how can you get involved? I have a few more links here on my page. I would encourage you, if you're not familiar with your state's single point of contact, to get to know him or her. The contact list is on our website at that firstnet.gov consultation page. We also have a list of the Public Safety Advisory Committee members, another great way to get involved. Stay in touch, keep an eye. We will be releasing our draft RFP, future public notices. I would just encourage you, if you're interested, our website has a lot of great information. We're often putting blogs out there, and there's a lot of different ways to participate. But I would say, if you do anything, the most important thing is to get to know that state's single point of contact. We are also very active on social media, and you can see some of our Twitter handle and some of the other links there. So with that, I will turn it back over to Noah. Thank you.
Thank you so much, Amanda. We really appreciate you and Kevin taking the time to go through all of this with us today. And now we'll have you answer some questions from the audience. A quick reminder about how to submit a question. Please click the question button at the bottom of the screen and then type the question into the chat box. I will read the questions for Kevin and Amanda to address. And we've got about 10 minutes left, and so we'll see how many of these we can get through. The first question is from the state of Arizona, and the question is, how will FirstNet address insufficient broadband access or communication infrastructure, particularly in rural areas? Maybe Amanda?
Yep, sure, so I can take a stab at this. As I had mentioned, the act that stood up FirstNet requires us to have milestones in each phase of our build to reach the rural community. So that's a major goal that we have, and essentially we will be working through that consultation process that I just mentioned, working with each state and territory to understand where there are current gaps in coverage and how we might work together to fill those gaps as we roll out the network over time. So again, that consultation process and getting to know your SPOC and making sure that your SPOC understands some of the challenges today is probably the best way to get involved and communicate those needs.
I would add, in terms of specific technology, and technology is changing all the time, so what we say today may not apply next year. But we've always known that we're going to have a core backbone system, which is a terrestrial system with cell towers and the sorts of things you associate with cellular communications or smartphone communications. But we would also have backups of satellite communications, much better and less expensive than they have been in the past. And then finally, deployables that we are experimenting with in some areas, which would not only bring a capacity in a large emergency, but could bring expanded broadband capabilities to places that have a huge number of people at that place for a short period of time for concerts or large-scale events, and then the people disappear. So those are some of the ways that we can see doing that.
Thank you both. Our next question is on treatment guidelines and SOPs for agencies. So EMS and fire agencies will likely need to develop treatment guidelines and standard operating procedures for using FirstNet technology to ensure that the device or the application that's being used will be efficient and safe. Will FirstNet develop treatment guidelines or SOPs for agencies to adopt or modify for their own use?
That's a great question, and I can say that the answer has not gelled quite yet. There will be a good deal of those types of decisions will evolve as best practices or applications, as an example, that may run over the network. And we certainly will maintain an app store or something of that nature so that applications that are found to be useful can be easily accessed. But actually, the SOPs for using the system, decisions about if we're using video a lot in a given EMS system, under what circumstances do we have to throttle that video or turn it down or turn it off so that in an emergency situation we can have other types of data flowing or voice flowing. Those kinds of decisions, for the most part, will be, as treatment protocols are today, a local, regional, or state decision that have to be determined by the folks around the table at the local, regional, or state level. And guided, yes, by national best practices that may come out of FirstNet or be developed through applications.
Great. Thank you, Kevin. We have several questions coming in about cost, as is easily anticipated. One of the questions is about how EMS agencies today, particularly in rural areas, but in urban areas as well, do struggle a lot with the cost of buying and maintaining technology. And so if FirstNet is to be sustained by user fees, how do you project to address agencies that might not have the funding to purchase and support even basic technology today, being able to support FirstNet technologies in the future? Amanda?
So I can start. So, yes, one of the ways we will be funded is through fees, but the other piece I didn't mention is that we have the ability to essentially sell off our excess capacity. So Kevin mentioned that beachfront spectrum that we have for this network. On the average day, we don't think public safety will need that full bandwidth all the time, so we have the ability to essentially partner with what we're calling a secondary user and bring in revenue for the network by leasing off that excess capacity. So that's one way that, in addition to the fees that we collect, that we hope we'll be able to keep the service fees fairly low and the devices fee and competitive with the commercial entities today. Kevin, if you would like to add anything more to that.
Well, I would just say that, yeah, EMS, like fire, volunteer fire, have limitations on what they can afford and oftentimes have to have dinners and bake sales to support that. And yet, show me an ambulance that doesn't have a cell phone in it. Few and far between. So the decision that's going to have to be made down the road by that EMS chief, whether it's a volunteer EMS chief or a large service EMS chief that has to put technology in 40 ambulances, they're going to evaluate whether they keep the cell phones they've got or smartphones they've got in those ambulances now or adopt a FirstNet device. And the FirstNet Board knows and staff knows that that's got to be an economical decision. So that's what's certainly driving our work, and we will only be successful if we can offer something that offers value, offers capabilities that don't now exist, and we know that will be the case, but also has to be economical, and that's the challenge for us.
Thank you, Kevin. And speaking of value, there's a question that came in that speaks to a particular need that this community has, and that is that a significant part of this community's responsibility is to transport patients from hospital to hospital. Will there be a way to move patient information or patient orders from the first hospital to EMS devices and to transfer that information to the receiving hospital under the network that we're talking about today?
I think absolutely. One of the goals is not only doing that, but being able to, in the field, by the time the patient, I talked about populating 4 patient databases in that car crash example. Well, the next step of that, once the patients are taken care of, is that that's all integrated into one health record, and that health record, with all of the 4 patient databases or pieces thereof, or web links to, like the video, for instance, in that patient database, will all go and be at the hospital before the ambulance gets there, perhaps without any voice contact between the medic and the hospital staff. Well, if you can do that, then certainly the goal is to be able to do interfacility transports in the same manner, that you're able, instead of picking up an envelope of the patient's, all of the patient's information and physically carrying it with you to the next hospital, that you will be able to have the patient's information on your computer before you even see the patient, or your smartphone or whatever, and that you will carry that to the hospital and at the other end be able to automatically download that through Bluetooth or some other capability. And in fact, that capability is already in many states today that have health information exchanges. Once you know that you're going to pick up Mrs. Jones at the hospital to go to a new hospital, you can go into the health information exchange and get a record down before you ever step foot in the first hospital.
That's great. Thank you so much, Kevin. And for our final question, I'll ask a very important one, which is about privacy and security of the information that's being transmitted across the network. What security protocols do you anticipate will be in place to assure the privacy of patients and the agencies using the network?
Well, I can tell you that we anticipate that the FirstNet network will probably be one of the prime targets of communications hackers and others who would want to bring a system down because of the people that it's serving, public safety. So security is absolutely, cybersecurity is absolutely job one as far as the network's capabilities are concerned. And they far, far outstrip any requirements that HIPAA may have or that patients would want to make sure that the system has. So that would be my quick answer. Amanda?
Yeah, I think that's a great answer, and that's definitely a topic in one of our that we covered and asked a lot of questions about in our request for information. It's also folded into that 15 statement of objectives that we'll be including in our RFP. And I can also say I know our CTO, our Chief Technical Team, is in the process of hiring a cybersecurity lead. So, as Kevin mentioned, absolutely critical and a high priority for this network.
Absolutely. And thank you both so much for the answers to those questions. With the time expiring, this will conclude today's installment of EMS Focus. I'd like to thank all of our presenters, Kevin and Amanda from FirstNet, and thank those of you who have tuned in for participating in today's webinar. Today's webinar is being recorded and will soon be archived on ems.gov for future viewing and listening. And as a reminder, for those of you who submitted questions but we were not able to answer them in time, we will send you personally responses to those questions. Our next webinar is scheduled for April of this year, and for information about future webinars and to subscribe to receive information about the EMS Focus webinar series, please visit ems.gov and click Email Updates on the top right. Thank you again, and have a great rest of your week.